Hi, I'm Josh McDonald.
And I'm Miranda Materi, and we are Hand Therapy Academy.
Let's talk about tightness in joints, and some of the different things that can cause it, and how we're going to kind of tease out which is which.
Yeah, so there can be a lot of different reasons for a person to experience lack of range of motion or tightness in a joint. And there's a few I think of off the top of my head. One is capsular. I think that's usually the most obvious. Another one is a peripheral nerve issue causing the loss of motion. The third one I can think of as musculotendinous, tightness. One could be skin, right? A thick scar can limit the range of motion. And then the last one could be something more psychosomatic. So those, or like a kinesiophobia or something like that. So those are the, what did I say, five? Those are, I think, the top five that I think of. There might be another one, but that's what I have off the top of my head.
Okay, all right. So let's go through capsular first. How do you know when something is a capsular tightness?
Yeah, so for this one, I think basically are how are they actively moving and how are they passively moving? And if those are equal, then I'm thinking that's or close. Sometimes you can get a little bit more, but if those are pretty equal, you're thinking that's probably more of a capsular adhesion and a problem within the joint.
Yeah,
And the same for like a bony block, that's still within the joint capsule.
yeah. So a bony block is going to be a hard end feel. Like when you try to extend your elbow and it only goes so far and it kind of goes thud at the end. That's a hard end feel. But what we talk about as a capsular end feel is when you get to the end and it's not a hard dead stop, but it is a really like dense end point to it. And that's what a capsular end feel is.
Yeah, and I think it's important to differentiate those, right? Because with the capsular tightness, you can make gains by doing, total in range stretching and low load prolonged stretching versus someone that has a bony infill. You're not going to be making gains in those.
Yeah, yeah. That could be heterotropic ossification. That could be bone spurs, could be hardware or loose bodies in the
Yep.
joint, all kinds of things.
It could be the sesamoid in the bone, right? That I've never seen that in my life, but we had a patient that had that. So you never know if you are feeling that. They need to go back and get X-rays and see the doctor.
Yeah, definitely. And then if we have a musculotendinous tightness, that's going to be where we have that active range of motion is not, I guess in either case, you're going to have that tension along the whole muscle line, and you're going to be able to identify a very soft end field. Soft is where, like when I'm reaching down to touch my toes and I feel that tension in my hamstrings, I could keep going. It's just more uncomfortable as I go, but there's resistance, but there's no hard point where I feel like, no, that's all I've got other than discomfort. And you feel that along that, the patient will feel that along that whole tendon line most often. So if it's a extensor tendon tightness on the dorsum of the hand, then as you do a fist, they may not feel it, but you include that other joint of the wrist that the muscle tendon unit crosses, and they'll really feel that tension along the pathway of that musculotendinous unit.
Yeah, that's a great description. I think also noting a difference between active and passive range of motion will tell you too. So if they have limited active but full passive, say for like a flexor tendon, then you're thinking it's a musculotendinous problem.
Yeah, yeah. Or another option for that same equation is it could be a scar adhesion. And
Yeah.
so if I can get that patient in a full passive flexion with a flexor tendon injury, so I know their joints are all intact and their muscle tendon units are intact because I get them full down, but they can't get that range, it might be that tendon stuck in scar, and that's what's keeping them from coming down further. And so then you work on a scar tissue issue.
Right. And scar was our next topic. So,
Yeah.
scar or skin tightness, that you can usually visually see, or like Josh said, you can also palpate it, or you can do it with your clinical exam with the active versus passive range of motion.
Yeah. Yeah. And sometimes you can watch that skin pull or drag or pucker or behave differently at that point of adhesion. And so if you like watch along that muscle tendon line that's supposed to be pulling and look for any abnormalities and how that's working, even compare side to side, you can watch that skin or scar line behave differently.
Yeah, definitely.
Yeah. And then a psychosomatic issue where the patient has maybe a fear of movement or they've got maybe a writer's cramp or some of those things. That's one where you're going to see that active range of motion is better than tolerated passive range of motion. It may be a pain response that they're like apprehensive about you doing stretching. It may be that they aren't like they're blocking and guarding against the movement, but that's one of the indicators, not the only one, where it's like, hey, they can move better when they're walking in the front door than when we sit down and start to move with them.
Right, if they're distracted or something, doing better. And sometimes it really is. I mean, I know that sometimes you're like, it's okay, just move it. But sometimes I think their body is really good at protecting them, right? So even though they may be telling their hand to move, their brain is saying, no, I'm hurt, don't move. So that would be an example of, something psychosomatic, which we still know, we don't say that problem's not real. It is very real, right? So we're not dismissing them or treating them differently. We're just trying to identify the cause, because our treatment varies for all these, right? What you do for capsular tightness is totally different than what you're going to do for a musculotendinous tightness
Yeah,
issue.
yeah. And when we say psychosomatic, that can be a term that carries some baggage with it. And we're talking about just the very basic, that person's body does not have a structural integrity issue in the limited part. There's other things going on, and those are very valid things, but we would treat those differently than I would. Let's say I'm going to use the modified Weeks scale to come up with a dynamic or static progressive or serial progressive splint for that patient with a capsular end feelers. I'm not going to use one of those for a patient who has guarding or kinophobia or those kinds of things, because that's just going to force it and make the whole perception worse.
Right. Or even for, like, same, you're not going to use a splint static progressive for a nerve tightness issue, or
Yeah,
for a shortened peripheral nerve. You're not going to do that. Your treatment definitely varies.
yeah, yeah. And so it's important to be comfortable with identifying, both based off of observation and physical feel, how much or why that person's not moving, so you can pick the right intervention as a result.
Right. Work smarter, not harder. So if
Right?
your patient is not progressing within the next, 2 to 3 weeks, it might be that you haven't correctly identified the right problem.
Yeah,
Especially if they're doing their home exercise program, they're doing everything you said, and they're not making those gains. It could be that they have a different issue, or they have multiple issues.
yeah. And I think that's something that 2 week mark is something I try to keep in mind, and is a great like um, clinical pearl to keep in mind, is that whether it's wound care or treatment progression or whatever, if you're doing something consistently and the patient is effective with their home program for 2 weeks and things aren't changing, you need to find something different to try. Again, whether it's wound or whatever, we should be able to make changes to some degree, maybe not fix the problem within a 2 week span, that we can say, hey, my pain is getting better, or my motion is improving, or my wound is closing with 2 weeks of intervention. If it's going to take more than that, then we got to kind of second guess what our choices for
Right.
treatment plan are.
And it's not to say we expect them to get better in 2 weeks. We just expect them to see them progressing along the continuum. And then make sure you're taking into account some of those other variables, like their past medical history, are they diabetic, those things, because, that can extend it out. So maybe it's 2 weeks for the healthy individual, maybe it's 2.5, 3 weeks for, somebody that has those comorbidities as well. But Josh is right. You should definitely see, and maybe even some with those medically complex patients, you probably should still see some progress at 2 weeks. It just might
Yeah.
be slower.
Yeah. And maybe it's using therapeutic use of self. Maybe it's using breathing techniques and saying, like, I need to go out from a completely non-biomechanical model, but we should be able to see changes in whatever we're working on with the patient. We should see some progress within that frame of time.
Yeah, definitely.
Yeah.
Or it might be time to refer out too, right? We don't want to be afraid of using our partners and our teammates.
Yeah. Yeah, definitely. All right. Well, if you have any questions on any of that, or if you're unsure about maybe what the modified week scale is, we have that information on our Hand Therapy Academy platforms. You can reach us on email at info@handtherapyacademy.com, or you can find us on all of our social media platforms at Hand Therapy Academy.